Okay, so welcome everybody. Thank you for joining us for webinar number 5 of the Shout series. My name is Diana Kaffa. I am one of the members of the Shout team, and I'm just going to walk you through a little bit of the background for this webinar before we get started with our main speakers. You can advance the slide. So just for those of you who may not be familiar with the Shout program, support for hospital opioid use methadone and buprenorphine treatment, CSF, supported by the California Healthcare Foundation, that is working with local champions in hospitals throughout the state and again throughout the country to build skills in inpatient medicine teams, on surgery teams, and on maternity teams for starting buprenorphine or methadone on patients with opioid use disorder. We are specifically focused on helping hospitals implement programs that will allow more than just a few clinicians to do this, but actually the whole hospital to do it. Next slide. The way we're doing that is by providing a series of tools to help you. So the tools that we have produced for Shout and are continuing to produce, first are a series of webinars. So this is the 5th in our series of 7 webinars. We have also developed inpatient buprenorphine and methadone guidelines that can be adapted to specific sites throughout the country. Perioperative and acute pain management guidelines for people who are on buprenorphine or methadone when they come into the hospital. Patient educational handouts, FAQ sheets, pharmacy and therapeutic committee monographs in case you need to work with your pharmacy to get specific medications on formulary. A grand rounds template so that you can educate people in your institution about these issues. And then we're going to be starting a series of interactive Q&A sessions, this actually being the first one, to help you work through some of the complex logistic issues that come up. You'll see at the bottom here a link to a needs assessment. If you are participating in the program and haven't had a chance to do the needs assessment, it's really helpful for us to get a sense of what needs are out there. We're really trying to tailor our programs to fit what people's specific needs are, and so we'd love to hear from you about that. Great. So this is the schedule of what we're up to. In November and December, we did some really education-focused sessions, trying to just get people up to speed on what the current science is on using these medications in the hospital. Today, we're doing a logistical support webinar where we're helping you really think through the logistics of implementation and trying to have a lot of Q&A time to help you ask your questions. We're asking teams to begin meeting with leadership, developing plans for implementation and get approval for the medications on formulary. Moving into February and March, we're going to be doing webinars specifically looking at barriers that people run into and how to remove them. We will also be starting our group coaching calls, which I'll talk about a little bit more in the next slide. We're asking people to try to set up a pilot in February and March where you do a few prescriptions maybe in your hospital or pilot a new aspect of your program as you expand it. And then April and June, our team is going to be available to do some grand rounds presentations, particularly in California hospitals to help. So the coaching calls, I'm the coaching calls. So these are calls which will really be open for you in a small group to talk about the issues you're having and problem solve them together. We'll be sending you an email that you can, we'll click on the link and you can join one of these coaching calls. Next slide. Good. So these are our upcoming webinars. We're in webinar 5. Webinar 6 will be focused on discharge planning, which is one of the big complexities people feel like they have to figure out before they get this stuff rolling. And then webinar 7 will be on pharmacy leadership in hospital-based OAT. So many of you may find as you move forward with this that you really need colleagues in pharmacy on board and helping to lead this cause. We have a team of pharmacists working, speaking about that. Again, we'll be sending you an email soon with links to register for those webinars. So for today then, We are going to be focusing on inpatient hospital logistics for opioid agonist therapy, meaning buprenorphine and methadone. We're right now doing a welcome and review of SHOUT. That's me. We'll be moving into a 20-minute presentation by Hannah Snyder, looking at legal restrictions and how we remain on the right side of the law as we do this, insurance coverage in California, and then finding outpatient partners is one of the key logistical issues people run into. And then we're going to have a lot of time at the end for Q&A, where we have some panelists. We go to the next slide. I think we have the names of people. Yeah. So here are the people who are participating in the panel. Again, me, Diana Kaffa, and then James Gasper, who's a pharmacist who works with the California Department of Healthcare Services, is very savvy about policy related to these things, about insurance coverage related to these things, and I think can be a huge help to all of us. And then Hannah Snyder, who's giving the main talk, will be speaking on the panel as well. Next slide, please. Additional material URL provided here on the slide to ask a question, and we do encourage you to ask questions throughout. There's a Q&A box. There's kind of a Q&A button at the bottom of your screen. So if you scroll down on your screen on Zoom, there's a little QA. Just click there, type in your question. I'm going to be keeping track of all the questions that are asked throughout, and then I will be speaking them for you to the panelists at the end. There's also going to be a few times when we ask you to raise your hand to answer some questions. If you go over to your right-hand screen, there should be a button you can click on to raise your hand. And to ask logistical questions about the webinar, you can use the chat to the host feature. So there's a chat feature also at the bottom of your screen that you can click on. All right. And with that, I want to hand it over to Dr. Hannah Snyder to teach us about inpatient OAT logistics.
All right, thank you so much, Diana. So my name is Hannah Snyder. I'm an addiction medicine fellow, and I'm the project lead on SHOUT. And today what we're going to be walking through is some of the most frequently asked questions that we've been getting from our SHOUT participants. We know that a lot of the issues that people face are issues around policies and regulations and insurance. These are unfortunately not the most exciting things to talk about, but we do think they're incredibly important for your rollout, and we're hopeful that this session can be useful to you. I think the session will be most useful if you're able to write in your own questions and really interact with us and let us know what barriers have you been facing. So thank you very much for that. So I'm going to get started by just talking about a little bit of the regulatory environment and some common concerns that hospital administrations have with regards to legality and regulations around buprenorphine. Who will only be administered in what's called an NTP, a narcotic treatment program, or otherwise known as a methadone clinic. Buprenorphine, on the other hand, must be prescribed by an individual who has a DEA waiver, or what we call an X waiver. And this allows any primary care doctor, addiction specialist, psychiatrist to prescribe buprenorphine. These restrictions both only apply to the outpatient setting. The DEA actually makes explicit exceptions that if the patient is admitted for any reason other than addiction, any provider can prescribe methadone or buprenorphine. And this actually includes for inductions in the hospital. So what this means is that if a patient comes into your hospital and is admitted for pneumonia, say, and that patient says that they've been using opioids and want to get off, or that they're starting to feel withdrawal, it is perfectly legal for providers in the hospital who do not have an X waiver to prescribe buprenorphine to those patients. Similarly, there's an exception specifically for emergency rooms and for urgent cares. We know that there can be long wait times to get folks into buprenorphine clinics or methadone clinics, and the DEA has actually given us permission to do a workaround here. So in emergency rooms and in urgent cares, providers are allowed to dispense buprenorphine or methadone as a once-a-day dose for up to 3 days. And the hope is that, say the patient comes into your emergency room, is starting to feel withdrawal, wants to get connected to a methadone clinic but can't do intake until Monday, they can get a daily observed administered dose in those settings. And I've actually put the citation down below. When you all get the slides, you can connect to that and use that to help explain to your hospital leadership how this is legal. We talk about how having an X waiver is actually not necessary for in-hospital prescribing, and that is completely true. But we do advocate for our SHOUT participants to get X waivers nonetheless. For prescribing in the hospital, but it's here on this call today is to help patients get connected to long-term maintenance treatment after an acute inpatient hospitalization. And therefore, we want to make sure that they leave the hospital with the medications that they need. A buprenorphine clinic might not be able to see them right away, and it's appropriate to write a bridge prescription on discharge for your patients so that they can connect to outpatient care. And in order to write that bridge prescription or a discharge prescription, an X waiver is necessary. Many hospitals have chosen to have 1 or 2 X waivered providers who are kind of in charge of writing the discharge prescriptions for the entirety of their hospital. If you or anyone on your hospital staff is interested in going through the X waiver training, which again we would advocate for, there are so many different ways of doing this. The American Society of Addiction Medicine has trainings, as do most of the professional organizations for NPs, PAs, and MDs. One in particular that I want to highlight is called PCSS MAT, and again, I have the link here on the slides. PCSS MAT is a really good resource for kind of anyone who wants to boost their knowledge about medication-assisted treatment for addiction. Specifically, they offer the X waiver training, and they offer it in a free online format, which I think can be really nice for folks. So you need to do 4 hours of online self-guided training, no matter where you're getting your training from. And subsequently, 4 hours of live training. That can be in person or that can be on a webinar. And actually, PCSS MAT will allow you to do that for free on a webinar. That's specific to MDs, that total of 8 hours duration of training. For NPs and PAs, the training can be a little more onerous. It's up to 24 hours, so you need an additional 16 hours of usually online training. And that's all available through the nurse practitioner and PA professional organizations. If you all have any questions about that or having trouble accessing or affording it, let us know and we can kind of help you see if there are any workarounds. So our hope is that you all will be able to use the raise your hand function on our new system. And we'd love it if you could raise your hand if your local hospital, the hospital you're hoping to work with, has at least 1 X licensed provider on staff that you are aware of. Go ahead and raise those hands. Okay, so I'm seeing about 9 of our 20 attendees, which is great. A lot of folks do already have access to X waiver providers in their hospital, but that means that about half of you don't. If there's any hospital provider on your staff who you would like to get X license trained and they have any questions or concerns, please feel free to send them to us. And this is a barrier that we can really help you reduce. Once a provider actually has an X waiver and is prescribing outside of the hospital, there are certain regulations that apply. In the first year of buprenorphine prescribing, the most that an individual prescriber can have as active patients is 30. Now, active patients refers to a person who currently has a prescription that is up to date, that is prescribed by you. So for example, if I prescribed buprenorphine for a patient 3 months ago and I gave him a 2-week supply and he never came back and saw me, that patient would not count as an active patient for me. After 1 year of having your X licensure, you can actually apply to get this increased to 100. And then after 1 additional year, you can apply to get it increased to 250. And those are new policies that have recently come into play that will allow us to prescribe for higher numbers of patients. If you are an X waiver prescriber, it is important to log all of your prescriptions for the DEA. And again, that's all of those active patients. You need to be able to have them on file. We actually have resources on our shared drive that will show you samples of how you can keep these patients logged in a secure, HIPAA-friendly way. Because buprenorphine is a Schedule III medication, there are some restrictions on how you can prescribe it. Again, in the hospital, you prescribe with your normal prescription services through your electronic medical record. But if you were to give an outpatient discharge prescription, you could either call that in, fax it with a manual signature, do a secure paper prescription, or in some cases you can e-prescribe. You need to have a digital signature, and not every pharmacy, when last I checked, has the capability of receiving these e-prescriptions for buprenorphine. So I'd say check with your local pharmacy first. So that's most of the regulations around prescription. The other thing that we're hearing questions on a lot is on 42 CFR and hospital administration having some potential concerns around patient data security. So 42 CFR is a regulation that I like to think of as HIPAA on steroids for addiction. It's a regulation that is really trying to make sure that we don't inadvertently disclose any information about a patient's substance use disorder. And so what it requires often is that we chart for addiction treatment under a separate electronic medical record, or you need to have what's called a break the glass function, where you're specifically entering a new part of the chart that is just for substance use disorder. And there are many additional consents involved for sharing information when you fall under 42 CFR. The majority of our participants will not fall under 42 CFR. So this regulation only applies if you're federally assisted and if you hold yourself out as providing substance use treatment. So most of us are probably federally assisted. This counts, so if you accept funding from Medicare, if you're under certain federal detox programs, some say, depending on your participation in DEA, that can count as well. Most folks are going to end up being federally assisted. However, most people who are hospitalists or primary care doctors who also provide substance use treatment do not count as holding themselves out as an addiction specialist. And again, just a caveat for everything that I'm saying here, I am a physician, I'm not a lawyer, so absolutely consult with your local legal team as to whether or not your particular practice would apply to 42 CFR. But normally what this means is somebody who is advertising services as an addiction provider, or somebody who is listed as an addiction specialist. Those would be people who 42 CFR would apply to. And specifically, 42 CFR actually has language that I think can make us feel much better about this situation. So it says that if you are an emergency room provider, as an example, and you're treating somebody for an overdose, you're obviously diagnosing them with a substance use disorder and addressing their substance use disorder needs, and then you're sending them into the ICU. That would not count as a 42 CFR applicable mode of care. That's just you giving them their regular medical care, which of course involves their substance use disorder. So I think for the vast majority of us, 42 CFR regulations likely don't apply. But again, consult with your own legal team. So those, I think, are the main legal issues that have been coming up. And I encourage you really to type into the Q&A box any additional questions or caveats or scenarios that you've been seeing around those regulatory issues that you'd like us to clear up at the end. I'd like to move on right now to questions of insurance coverage and the different formulations of buprenorphine, because this has been changing really rapidly. So there are many new formulations of buprenorphine. What we're all most used to, and what I prescribe the vast majority of the time, is just sublingual buprenorphine, either in the tablet or film form. And that's specifically covered for the indication of addiction. Buccal is also covered for the formulation for addiction and is FDA approved for addiction. That's something that we use a little bit less. Formulations such as the patch and the injection are actually specifically approved for pain indications. And so for the vast majority of the time, particularly in the outpatient setting, these are not medications that we should be using for addiction treatment, and actually it's contraindicated. There is some flexibility on that in the inpatient setting when someone's acutely withdrawing. There is the potential to use the patch or the injection, but if that's something that you're considering, talk to us about that a little bit more. And then two new forms of longer acting buprenorphine have recently come out. First is the subcutaneous injection, which is a monthly injection. This is not yet commercially available, but I believe will be in the next year. It's a once-a-month injection that you can get at any physician's office as opposed to in a pharmacy. And the other option is an implant. Now, both the implant and the injection are covered as medical benefits as opposed to pharmacy benefits. So that what that means is as, say, a primary care clinic, what you could do is purchase this medication and then when administered, bill Medicaid or Medi-Cal for that. I'd like to take a moment to talk a little bit more about this implant formulation. We've been getting a lot of questions about it. So this is very much in its early form, and it's not something that we've been using ourselves. And it's only able to be implanted by folks who have a particular training and are monitored through this REMS program. It's kind of like the early days of the implant birth control. The implant on birth control. So it's 4 separate rods, each of which is 1 inch long. And the implant will give a steady amount of buprenorphine for approximately 6 months duration. So this could be a good option for a lot of our patients in the future, but it's still, I think, a little ways off for most of us. So to speak a little bit to the insurance coverage, I will be talking more about California here than other states, just because it is so variable state to state. But I think in California, at least, we've been making a lot of strides in terms of coverage of buprenorphine. So if a patient is on Medi-Cal, including the managed care plans, buprenorphine in the sublingual and buccal forms should be covered. And it's specifically covered by this carve-out fee-for-service. So sometimes we'll hear that pharmacies are saying they can't bill Medi-Cal for it, it's not covered. If you talk to the pharmacy and say, can you please bill it to the fee-for-service carve-out, they should be able to get it covered, and it shouldn't require any prior authorization. That changes a little outside of Medi-Cal plans. So Medicare Part D plans are, of course, variable, but for the vast majority of plans, it will be able to be covered after a PA is done. So there may be quantity restrictions, there may be other limitations, but usually with a prior authorization, you should be able to get your buprenorphine covered. Private insurance companies are even more variable. So there's been large strides recently in some of the large national insurance companies, including Anthem, Aetna, and Cigna, have all actually recently put buprenorphine on formulary. This is huge news, and I think it's going to make it much more accessible for many folks. However, there are a variety of other private insurance companies that have additional regulations. So you need to have failed other treatment as first line, or they only give you a very short approval period, other barriers such as that. That's something that I'm hoping that we can advocate on a national scale. Buprenorphine should actually be a first-line treatment for opioid use disorder, and you shouldn't have to fail other forms of treatment first. And I think we're moving in that direction, and I'm hopeful that it'll be added to more insurance companies' formularies in the upcoming years. In California, we have a recent development of drug Medi-Cal, which I want to take a moment and address as this has been coming up a lot as a question. So drug Medi-Cal is intended to improve access to medication-assisted treatment, with the caveat that this really only applies to very certain situations. So about 40 counties in California have applied to have a drug Medi-Cal extension, and as far as I know, about 7 have actually started to have drug Medi-Cal implementation. What drug Medi-Cal does varies county to county, but the most important part of it and the required portion of it is that they're required to provide access to an NTP, a narcotic treatment program, or what we usually think of as a methadone clinic, and that in those NTPs, they're required to offer buprenorphine, methadone, naloxone, and disulfiram, just those 4 medications. There's a lot of flexibility in drug Medi-Cal, and some folks are using drug Medi-Cal to pay for a wider variety of medications for alcohol use disorder, to offer these medications in other sites outside of NTPs or in mobile vans, but that's not the case across the state. So I'm wondering if, as far as you all know, you can raise your hand if you have, if you are currently living in a drug Medi-Cal expansion county. Okay, so only 3 folks have raised their hands. It's possible that you don't know yet, or that the expansion hasn't yet occurred, but I'll post a link to the list of drug Medi-Cal expansion counties. It might be helpful if you are in one of those counties to contact your local office and have a conversation about how you can better access buprenorphine on discharge for your patients if you are in a drug Medi-Cal expansion county. The other thing that drug Medi-Cal does is provide funding for additional modalities of care under the ASAM criteria. So it should, for most folks, be starting to fund more outpatient services, intensive outpatient, residential services, and even intensive inpatient services. Again, these are going to vary county to county, but you should be seeing an expansion in the coverage and reimbursement for substance use disorder treatment if you are in a drug Medi-Cal county. All right, the final main issue that we wanted to make sure that we address today before we move on to our Q&A section, and again, please continue to put questions in as you see them, is just how to find outpatient partners on discharge of your patients from the hospital. And this is actually going to be the entire topic of conversation for our next webinar on February 14th, where we will go in depth into how you can do discharge planning and various models of care. But I want to get you started with some options for how to find local partners. So first and foremost, many of the SHOUT participants are actually outpatient providers already. And so if you're a hospital provider and you're really looking for outpatient clinics to link your patients to, please let us know. And we can look at our SHOUT list and see if any of the community clinics who are involved with us would be a good place to take your patients. The other good ways to find outpatient clinics for continuity is via the SAMHSA database and also through the new hub and spoke rollout in the state of California. So the SAMHSA buprenorphine treatment finder is a really useful tool that we've mentioned earlier in the session as well, that you can find on the SAMHSA website, and you can actually plug in your zip code or your city and your state, and it'll show you a list of X-waivered prescribers in that community. It's not a perfect list. We've certainly seen that it's not updated with most recently X-waivered physicians, but I think it's a really good starting place. Many of our participating hospitals have had success with looking up prescribers on this database and just kind of cold calling the clinic and saying, hey, does Dr. X feel comfortable prescribing buprenorphine? We see that he's X-waivered. Would he be willing to take some of our patients? If that provider says, I'm not ready to take buprenorphine yet, let us know that as well, and we can see if we can help with that and build that individual's confidence. The final poll that I want to take is to see if, to the best of your knowledge, any of you are currently in a hub and spoke county in California. And if you don't know what that means, that's okay. We will discuss it in just a moment. Being in a hub and spoke county can be a real benefit to you as you try to do this rollout. Okay, so again, we've got about 3 of our 23 listeners who believe themselves to be in a hub and spoke county in California. So this is a map of, when last I saw it, all the counties that are involved in the hub and spoke rollout in California. And then you can see it's actually a wide variety of counties. It is not affecting everybody, and there are, as you can see, many counties that are not participating. But the hub and spoke model can really be beneficial to you as an inpatient provider looking for a place to discharge your patients. What the hub and spoke model is government funding to support usually an NTP or a methadone clinic in serving as the central hub for buprenorphine prescription in the community. Most patients will start out in that hub program, often in a very structured NTP environment with daily observed dosing, and then we'll move on after stabilization to a spoke. And a spoke is usually a community clinic that's near to that hub, and the hub will continue to give mentorship to those spoke sites. It can be really useful to contact your local hub site and say, you know, we're starting to do some buprenorphine inductions in the hospital, and we would love to be able to discharge them to your clinic. Would you be willing to take them? And most of the hubs, as far as we found, have actually been very actively searching for new patients, and I think would be very happy to take your new buprenorphine discharges from the hospital, as well as methadone discharges from the hospital. So that's actually it for the main didactic portion of our section today. Again, we really want to make sure that we have a robust discussion. So please write in any questions you have. And it looks like some of our panelists are eager to share some additional information. So I'm looking forward to that. The key points that I want to make sure that you're taking home are that we've really switched from a didactic form of SHOUT now to an implementation form of SHOUT. And we're hopeful that you'll be able to start doing pilot testing of inpatient buprenorphine and methadone inductions in your community hospitals in the next month or two, with the goal of doing a full rollout by July. X waivers are not necessary inpatient. It shouldn't be a barrier to you getting this started, but it's a great option and helps your patients connect to care, and they can be free online, so there's really no reason not to do it. If you're having difficulties finding partner outpatient organizations in your community, let us know. Use your local hub or use the SAMHSA Finder database to find clinics. And then if you are in the state of California, for most of our patients who are on Medi-Cal, the Medi-Cal will always cover the buprenorphine, and I think we're starting to get more options in terms of coverage of that buprenorphine, which is great. So I'm going to turn it back over to Diana to lead the Q&A portion of our discussion today.
Great. Thank you, Hannah. I think that covered some real sticking points for a lot of folks. So it looks like we have, our participants have not been able to type questions in the Q&A box. So what I'm going to ask you to do is two things. One, as attendees, if you could type your questions in the chat box, I will make sure that those get read out. We're also going to try, if you want to try raising your hand, we are going to try calling on you and unmuting you so that you can just ask your question verbally. So you can have a choice. You can type in your question or you can try raising your hand. Okay, I have a question here. Before that, I know, James, you had a few things you wanted to comment on just as we get started.
Sure. If we can go back to the 3-day rule. We started off fairly early on.
It was on slide 13.
Almost. Back a few more.
There we go.
That's the one right there. Yeah, just a point of clarification that the DEA has this 3-day rule that says that you can administer any opioid for the treatment of opioid withdrawal with the purpose of referring a patient to treatment. And this can be done in an office setting. It can be done in an emergency department. It can actually be done just about anywhere, but it has to be directly administered. It cannot be dispensed. It can't be prescribed, and you cannot renew this 3-day period. It's a very useful tool for bridging patients under all circumstances, and we believe that it covers the emergency department administration of buprenorphine even in the absence of a waiver. So it's very useful. Just wanted to clarify that point.
Great. And then you also mentioned, James, in our chat that the number of people who you can prescribe to at any given time has changed.
Oh, yeah. So the upper limit's 275 after 2 years. You can apply for that extension. There's been very few in the state of California that are at that level. But
yeah.
It is an option, and particularly if you have a busy primary care practice with a lot of support staff, you actually may be able to push into that ballpark.
And I think this is an example of how quickly the regulations are changing right now. So it was bumped from 100 to 250, and then more recently 275. And it's the kind of thing that happens so fast that I think most of us don't even hear about it as these changes happen.
And hopefully someday there won't be a cap.
Yes, that is the goal. Great. And then one other point of clarification I saw you talk about was this drug Medi-Cal expansion.
Yeah. So just to clarify, every Medi-Cal beneficiary has access to drug Medi-Cal services. It's an entitlement, which we largely think of as being a methadone maintenance. It also includes outpatient counseling. The expansion refers to counties that are opting into a new level of service, which is using the ASAM criteria. And along with that, depending on their county implementation plan, they're picking up things like case management, coverage for physician services, which is not a statewide drug Medi-Cal benefit. It doesn't pay for physician time to see a patient in an outpatient setting. So things like that are coming into play in the counties that are expanding. So there's a whole lot of new things that are coming in. Just to clarify that beyond methadone, the other medications in an NTP, buprenorphine, disulfiram, and the naloxone distribution is only going to happen in opt-in counties. So across the state, if you have a methadone clinic that's not in an opt-in county, they won't offer those additional medications. The other important point about drug Medi-Cal is that we don't have NTPs in most of our, counties, particularly in rural areas. So about half of the state doesn't have an NTP available to them. But they do have outpatient counseling services in those places.
Great, thank you for clarifying that. I see one comment from a participant saying that you have a waiver for 275 and probably have about 100 active patients. So that's great. You're doing a lot of service in your area. There's also a question. If a patient comes through the ER with an overdose, do they get Narcan first to precipitate withdrawal before starting Subutex? What is the best practice? Does anyone want to take that? I can jump in.
If they had an overdose, we definitely want to reverse the overdose first.
Right.
That's going to be the priority. It's not necessarily to precipitate withdrawal, but to treat their overdose symptoms. And depending on the duration of the drug that they've taken, it may or may not be time to consider buprenorphine. You're likely going to be waiting that one out by, another 12 to 24 hours before they're an adequate withdrawal to begin buprenorphine. We wish we could shorten the window, but it's unlikely to happen immediately after an overdose.
Mm-hmm. Yeah, I think that's exactly right. I think the same. Go ahead.
I would just say, those patients are not always, and probably most of the time, not getting admitted to the hospital. But when they are, I think it's a beautiful moment for change. And so starting buprenorphine at that time can be a really great idea. There is a technique that I think has not been adequately studied, but just so you know about it, because it is out there. Some places are actually using buprenorphine itself to reverse overdoses and then bridging that into buprenorphine treatment. But again, that has not been actually, to the best of my knowledge, fully studied, and we don't know the safety profile of that technique.
Yeah,
there was a few early case reports of it being used on the street to reverse overdoses, which I thought was fascinating.
I think that it is happening on the streets. Yeah, people know that it is a little bit of a gentler way to reverse an overdose. Yeah, but not standard of practice just yet. Other questions? All right, I'm going to give people just a couple more minutes to think of some, but we may have a pretty quiet Q&A session here.
So one question that I've been hearing from a couple participants that I was wondering, James, if you could comment on, was the implants and injections for buprenorphine. And do we think those are going to be more common? Are they going to start to be kind of covered by more private insurance companies? And are we seeing them really be used yet? Or is that still kind of pretty far down the line?
Yeah, I'll comment on my personal thoughts and also on the policy on those in the practice. The implants are problematic for a few reasons. One is that they hit a fairly low therapeutic dose, equivalent to about 8 milligrams a day. And, we know from research that 16 is probably where we want patients to be. We get the best outcomes and the best retention at higher levels than what the implants hit. The second piece is for a maintenance medication. I don't know how practical it is to be doing these minor surgical procedures over and over and over again. I think they do have a limit on doing it twice, I believe. Anyone can correct me on that. Mm-hmm. So, looking at the long-term use of it, I think it's limited by the procedure that's required. So those are two issues, and I think it's kind of limited its utilization on top of access, which is a buy and bill medication. The clinic would have to pay for it out of pocket and then turn around and get reimbursed for it. And in FQHCs, it doesn't work that way because they have capitated reimbursement that pays for everything that happens to that patient inside the visit. The medication's not reimbursed separately. So there are some cost issues. For those that do buy and bill, and we do have Medi-Cal providers and private practices that do it, they can get it through a TAR. There is a procedure code for it, and I know that there have been some used in the state. So that's where the implant's at. The injectable is not going to be available until, I heard, the end of March, maybe the end of the first quarter. So we haven't seen any of it yet. It's not on the shelves, and they don't have a procedure code. The first way that it becomes available would be similar to the implant. It would be through a procedure and office buy and bill process, just about the same. But again, we're not there yet, so we don't actually know. I do think it has some particular advantages. It hits a higher therapeutic level. It's a good way to avoid diversion. And, for patients that are stabilized on Bup and need minimal contact time, it's a very convenient way to kind of get them back to their daily schedule and not have to chase around. They're picking up their medication and all the other components of refills and so forth. So I think there are some advantages to that.
Great. One of the other questions that often comes up is about the difference between the buprenorphine mono product and the combination product. Some people wonder, if we start patients on just the mono product in the hospital, because often that's what's on formulary because of cost, are they going to notice any difference when we switch them over? And then also pros and cons of using that in pregnancy.
Yeah, so I want to make a comment that the mono product's price advantage has the potential to expand access, across this country in many ways. And I don't know if we ever fully realized it. So the fact that it's cheap is almost more important, that it might have a slight greater risk of diversion and abuse. And I think the marketing of the film and of the combo product may have bypassed that important pieces, that we actually could have had more people treated if we used it. On the other hand, there is some preference for it. When you look at the discriminative stimulus test, people would pay more money for it. It's minimal, but it does exist. There is some preference by patients, because they don't like the taste of the combination product. I've heard that naloxone has a little bit more of a bitter flavor to it. So patient preference may be a piece of it. The third is in pregnancy. I mean, really, naloxone is not particularly absorbed when it's taken sublingually. So it's ideal to be as clean as possible. But do we need to switch every pregnant woman over to the mono product? I don't think so. But again, if you're not too worried about diversion and you have somebody that's carefully monitored, then why risk the exposure of the naloxone, even though the risks are very small?
That's really helpful to get that perspective. Hannah, do you have a question for James?
I was just going to restate the point that if you have a self-pay patient, I wouldn't hesitate for a second to give them the mono product.
Yeah.
It's definitely the way to go. And if you work within, an indigent population that doesn't have, access to Medicaid or to any other reimbursement mechanism, that's really going to probably be your go-to.
Yeah, I think that's exactly right. And I think we get into this story about how it's the naloxone that keeps people from abusing the medication, when in fact the medication itself has some abuse deterrent properties.
And relative to everything else that's available in the community, and it actually has a very low abuse potential, particularly for people that are opioid tolerant.
Yes. So there's another question that came in through the Q&A. For unstable patients on the injectable, would there be any risk of OD if the person tries to override it with a high dose of a full agonist? But if so, maybe still less risk overall, I suppose.
Yeah, when you look at the serum levels that are achieved with the injectable, they're, like I said, therapeutic and probably similar to 16 or more of the sublingual. And you get pretty high percentage of new opioid receptor blockade at that point. So they could potentially try to override it, but it'd be very difficult to do. What's more likely is they're not going to get high off of their opioids, so they're going to drink, take benzos, use stimulants. It's all the other drugs that go along with it that are probably going to be the problem and not necessarily the opioid.
Yeah. And I think that's actually really an important point, regardless of whether they're on injectable buprenorphine or sublingual buprenorphine. The risk of overdose when taking another opioid is not actually substantially higher. It's really the risk when using sedatives probably that is somewhat higher. Does that sound right?
Yeah, I mean, the risk is almost non-existent if you're on a maintenance dose of buprenorphine.
Right.
Because it's acting as a complete antagonist in the face of the opioid that's being consumed.
Exactly. So it's not going to increase your risk when you take another opioid.
Yeah, no, and it has such a high binding affinity, it's really hard to reverse it. And I mean, it's partly an issue, in the acute care setting. You guys are aware of this, managing pain with opioids, and somebody that's on buprenorphine takes, a little bit more fentanyl than you're used to.
Yep, that's exactly right. Okay, Dr. Schneider, you had a question about 42 CFR.
Yeah, one of the questions that we've been pretty commonly hearing from our SHOUT participants is some concern regarding 42 CFR, specifically if a hospital opts to have a structure for buprenorphine and methadone injections where they have one or two people who is kind of dubbed the addiction specialist for the hospital. Some hospitals have been using models where one of their hospitalists is in charge of the buprenorphine injections, and others have been using models where an outpatient addiction specialist is coming into the hospital and giving advice on the buprenorphine. I've been hearing questions from participants about, in those cases, do the consultants need to comply with 42 CFR and have a separate documentation process? And I was wondering if either of you could comment on that.
I think it's really about the institution. It's a program. Does the institution hold itself out to be providing those services? And I'm not aware of any hospital that's not specifically a chemical dependency detox that does. Most hospitals say, we provide medical care. You come in here and we're going to take care of all of your medical needs. Even though they have specialists inside that may be addressing substance use disorders, I don't think it applies because the institution doesn't promote itself in those ways. And again, it's always ancillary to some medical indication. You're only able to stabilize through opioid addiction if they're there for another reason.
Mm-hmm. Great. Yeah, that's an important point for us to emphasize that I don't think I made clear before. So as much as we would like to give everyone buprenorphine in our hospitals, if a patient is simply presenting for opioid, for the desire to get onto buprenorphine, that's not something that a regular hospital would be able to admit them for and induce them onto buprenorphine. It's only if they're presenting with another medical or surgical issue. This is one of their other medical issues that needs to be addressed.
And there's probably ways to bypass that if you're a licensed NTP as a hospital, or if you have a buprenorphine waiver provider. I mean, there's ways that you could do it, but it's pretty unlikely.
Great.
One other series of questions that I think is relevant. So those of us who practice in the outpatient setting know that we may get visited by the DEA to look at our documentation and make sure we're not going over our 275 or 30 or whatever it is that we're allowed to prescribe to. Have you heard of any hospitals getting those visits, and do you have any sense that might happen? And do you have any guidance for hospital providers about what kinds of documentation they should have in place in case that happens?
I think they have the cleanest, record keeping on the planet because of the administration of drugs. I mean, it's, it goes from, the pharmacy into the patient's mouth, and there's a trail the whole way. I mean, the DEA only cares about diversion. That's what they do. And diversion within a hospital happens, but it's not going, the highest risk situation is not going to be the administration of buprenorphine to a patient there. It's going to be, their opioid supply chain in general. It's going to be fentanyl in the OR. I mean, there's many other places that diversion happens in hospitals that I don't think the DEA would be concerned necessarily with treating people with opioid addiction under those circumstances. That's just my opinion. And on the other hand, I've heard on the streets that these site visits may become less and less frequent.
As they realize that they need to just let us prescribe buprenorphine.
Yeah, I mean, what I've heard is that it's not a priority for the DEA. at this point. And I haven't actually heard of anybody, getting a visit in a long time.
Yeah.
I remember, finding out about a monthly basis that somebody was getting visited, and like I said, I think they're fewer and far between.
Yeah, that sounds right. And I think probably the main thing for us to keep in mind in the hospital is that when we write a discharge prescription, we probably do want to log that, because that's the real prescription that needs to be logged.
Yes, absolutely.
I have another question here from the Q&A box. For inpatient stays, can patients receive methadone throughout the stay if the diagnosis is opioid use disorder? So I think that depends on whether that's a diagnosis that the patient has or the admitting diagnosis, right? If a patient is admitted with a heart attack and has opioid use disorder, then there's no restriction on methadone prescribing in the hospital. If you admit the patient for opioid use disorder, then I think it gets a little more complicated, right?
My understanding is that if the only thing that you were doing is treating their opioid use disorder with methadone, you would have to be registered as a narcotic treatment program.
Right.
Which is not impossible, but yeah.
Right.
But
if you have a medical issue for which they're hospitalized, then you're covered.
Yeah. And, by and large, I don't know if opioid addiction by itself is going to meet the acuity criteria that's necessary to have the stay paid for, depending on, who the insurance is. So
yeah,
it may be hard to have somebody in-house just for that diagnosis. But as long as they're there for something else, you can, induce them on methadone, titrate them, get them to maintenance, and, come up with a discharge plan.
Did that answer the question of the questioner? You can retype if you have more clarification you want to add.
And I think what we're seeing is that different inpatient settings are very variable. Clinical settings can have many different regulatory requirements placed on them. And here on this webinar, we're able to give kind of like some general advice based on our personal experience. But if anything specific is coming up for you that you think might be out of the norm, either let us know or reach out to your hospital's legal and regulatory teams, and they can best answer those questions. Okay,
great. So in fact, we have our emails here. I think you probably just said that. And the substance use warm line, did you highlight that, Hannah?
No.
Yeah, so we also really encourage you, as cases come up with things that you are struggling with or have questions about or are making you curious, or for whatever reason you want to be in touch with somebody, not only can you email Project Shout, but you are invited wholeheartedly to call the UCSF Substance Use Warm Line. We really love receiving phone calls, and and we want more.
You get to talk to me.
Yeah. So James.
If you guys want to talk to me, call the warm line.
But we have a whole team there that is really eager to help you with the more complicated issues that come up again. So please take that number down, put it in your phone, share it widely. And I think next, then, just as the last thing to highlight, we will be sending out an email to you with a link to the webinar recording so that you can share it with people, the slides, so that you can take some of those citations and use them in your discussions with team members, an opportunity to register for the next webinar, an opportunity to register for group coaching calls. And as a reminder, our next webinar is about discharge planning. How do you make the transition from starting these medications in the hospital to continuing them in the outpatient setting and helping people really make that connection and launch effectively? We're also going to talk about emergency room inductions, which are a huge part of this. Many of these patients, as we alluded to today, will come into the hospital to the emergency room and not even need to be admitted. They just need to be started and then transition to long-term care. So we're going to talk about all of those things on Valentine's Day, February 14th. And we look very much forward to chatting with you then. Thanks a lot to the panelists today. All right.